Is that the nod that we can make a start, Joe? Yeah, right. When the tech's ready, we can go. Oh, look, good. Right on cue. Right, welcome, folks, to the board meeting. Welcome to everybody in the room, and welcome to the people that we've got online. Hopefully, you can hear us all, and the tech will work. In terms of just new people in the room, I want to welcome Lisa. This is your first time stepping in for Eric, so welcome. And we do have Rachel with us in place of Ben, but actually this is not Rachel's first board, so there you go.
Also got Zoe, sorry for me.
And we've got Zoe as well. It's not your first time here. I've seen you here several times before, so that's fine. Great, welcome, folks. Lisa, any apologies? There's the obvious ones, isn't there?
Yes, Janet, Vicky, Eric, Pauline and Ben.
Okay, thank you. And so Pauline's on leave, but several of those people are down in London at the moment, which is why I've had to step into the chair. So our thoughts are with them in London as they're down there. Any declarations of interest that people need to make relative to this agenda and this meeting? If not, no, we'll move on. Minutes of the last meeting, let's not go through them page by page. I'll just pause and see if there's anything that anybody wants to pick out. With you, Martin.
Russell, just one if I can, just on Paul's story. As we know, that was a pretty impactful story that we had at the last meeting. Lots of really good conversations as a result. There were a couple of areas that we particularly homed in on. One was around the crisis care centre and some work that is ongoing around the crisis care centre. And the second was around service user feedback. And again, Kenny, you talked through that's subject to review, and I think there's a PIP in place. I just think we need a paragraph in that section just to sort of capture a little bit around those two areas that in particular came out of the story, and the fact that there is some work ongoing and that's going to be reported into the Quality and Safety Committee. I'm happy to put a few lines together for Lisa if there's an agreement that I think we just need a little bit more in that body just to show some of the key bits that we've picked out. And we're taking away to do some work on as an organisation.
Okay, I think it's good to just make that point. Joe, you raised your hand.
Yeah, I was going to say, obviously there's the official written minutes, and that's really important there as well. But the whole discussion and the is available permanently on the website as a video record as well. But
brilliant. And again, I've watched the video back again because it was that powerful. But as I say, for me, just reflecting in the minutes, I think we just need to just pick out those two key areas within my view.
Thanks. Do you want to say a few words, Kenny?
Yeah, so I would agree. The two key areas were experience at the Crisis Care Centre. We're undertaking a review and we'll bring that through the Quality Committee. And the second really was about how do we prepare people for what recovery might look like in mental health services. And I think Paul's experience was about if he'd have known then what he knows now, he may not have been as anxious, or he may have prepared himself more differently. And I think the more we can do in that space, the better. So again, we can make sure that we bring that back through committee as well.
Yeah, good point. Thank you, Martin. Anything else on the minutes of the last meeting? Are we fine with those? Okay, thank you very much. Let's go on to the actions. There are two. Well, actually, technically, there's three. The first one, I think, was fulfilled in the meeting. I think that information came through whilst we were there. Kerry, thanks for that. And the second two I know are complete because I've been receiving this. So the guidance has come out for decks of interest, and also form has come out, Lisa, thank you very much, to make it a bit easier to fill in. So those are complete as far as I'm aware. Thank you very much. Great, that brings us on to the patient story, and I think we've got Ruth with us online, haven't we? So how are we doing this?
I think Zoe will just introduce.
Perfect, with you, Zoe.
Hi, yes, Ruth is online. Good morning, Ruth. So we're just about to see Ruth's story. Ruth is actually an employee with us at the meeting. She talks through her story and journey from receiving house services right the way through to actually working and delivering services. I'm sure after the story it'll generate quite a bit of discussion, but I think we'll have a share.
Great.
people on people on the call, we're just going to have to restart Teams to install a driver. I do apologise for that.
Right. Okay. If this just doesn't work, do we have a fallback plan?
I'm trying to think on the fly.
Let's give it another minute and then we'll see. Yeah. We can move on if necessary. Oh, that was hopeful. Well done. We kept the faith with you, Joe. We kept the faith. Excellent. Well done. Good. We're in.
I'm Ruth. Constantly that
Amazing, wasn't it? Thanks for showing the film. First comment from me, which is just to say thank you, Ruth, for a tremendously moving story. And what a journey in a short space of time. Absolutely astonishing. Also, this it feels to me like this follows on a bit of a theme from the last one that we had last month with Paul. This is about, changed lives, but it's also about reflecting on what we could do better and being brave to do that in a public board meeting. So this raises some questions, but really, really excellent. Let's see if we can just open it up for questions, and I want to make sure that we've got Ruth back on the screen if we can. We'll just make sure that let's see, we'll go round. Thank you, Ruth. You're back with us now, we can see you. Great, let's just see if there are any comments around the room or indeed on the screen. Go with you first, Roger.
Thank you. Hi, Ruth. I'm Roger Banks. I'm the execs. Nice to meet you. I think we discussed this at Quality Committee the other day, and one of the things that struck me, particularly from what you were saying, was the need for a sense of continuity of treatment and support. And we were making the contrast with perhaps previous stepped care models in things like anxiety and depression, where you had to sort of succeed in one step before you could go to the next, and there's all these discontinuities, and then how you compare that with different models that actually are seamless and respond to individual need according to particular time circumstances, how treatment is going, etc. And I wonder what you feel would have helped that happen more effectively for you. What would have enabled you to feel as if there weren't gaps in which you were left waiting?
Yeah, can you hear me?
Yeah, we can.
Sorry, there's a lot of noise going on here. Yeah, I think, as I said in the video, I think it was very much like you start doing all this work with all these doors, and then, okay, we can't reach your needs, more help, so we're just going to stop. And then we've got to wait and start again. So, yeah, I think for me, it's too much like two different services. So really, those services working together, so it's that continuity. You're not just leaving one person and then waiting and then starting again. Why can't you take that person with you? Why can't the system work like that? Or why can't there be like a handover period or something like that? That people who really know me, I was really happy with care when I was under wellbeing, but when I was moved over to the Ashton, within a couple of months, I had one appointment with a psychiatrist, and I came out and I was really angry. I was like, everything that was agreed, and now everything's up in the air, and got to wait for this person, and wait to be discussed, and then there's just too many stops and starts. And then obviously when you're not in a good place and you can't advocate for yourself, it's really easy to lose hope and just to quit. I would have dropped out of services if it wasn't for the fact that Emma at Wellbeing spoke to me a bit even after I left. After I contacted her, so I was like, I need somebody who knows me to support me. I would have dropped out of services because I just found it too traumatising, having to go through all those hoops and not having anyone to speak to, or having to wait to speak to someone, wait to be allocated, and then they're off sick, and yeah, it was just like, I just didn't need all that, it needed to be easy to get the help I need, not like running a gauntlet, so to
Who's
speak.
best to respond on this point?
Yes, thanks for that. I think sometimes a way of addressing that is people being allocated, like care navigators, care coordinators, somebody. In the past, when I worked in Liverpool, we kind of had this idea that you had a kind of care support person bolted onto you as you kind of entered services, and they kind of stay with you throughout the various steps and so on to ensure that coordination and continuity of thinking and making sure that people don't contradict each other in terms of plans and so on. Sometimes that works, sometimes that's not necessarily the best solution, but
Yeah.
I think it's worth thinking about.
Yeah, thanks, Roger. I think you've asked a really important question. So, Kenny, if you don't mind just saying a bit more about that.
Yeah, thanks, Roger, and thanks, Ruth. I think it's really important. So, it's something we certainly need to look at. So, we have, for certain parts of our services, we have approaches where people will have a key worker, historically a care coordinator, that would do that transition work. So that essentially would make sure you had oversight of your case and a single person to contact until you were picked up by the next service. But that doesn't apply and hasn't historically applied in some of our psychological services and wellbeing services. So it's certainly something, I think, as part of our care planning work and establishing what we now call key workers, we need to consider about how do we make sure that transition, that handoff, if you like, from one type of therapy or one type of service to another doesn't just leave people waiting with no support. So I think it's a really, really good point, and something we need to make sure we look at across lots of different services rather than perhaps just an isolated few. So yeah, really helpful, I think.
Okay, thanks, Kenny. Let's go over to Zoe.
Yeah, so thank you. Yeah, and in addition to that, Kenny, I think it's a really good point, and there's a lot of work underway currently, isn't there, in terms of the pathway work that we're doing, and community pathways. We're doing some interfacing between, crisis and inpatient pathways, but equally, I think we need to think about joining up through those primary services into secondary services and actually making sure that those pathways are fluid. And actually, to another point you made, Ruth, in terms of having almost jumped through hoops to get to where you needed to want to, so it's not just them being fluid, but it's being flexible around person needs. So I think they're really good points that we can pick up and really take through some of our work that we've got underway already.
Good. Let's just take a few more comments and then I'll just come back to that point. Anything else that people want to raise? Go ahead, Martin.
Just one there. Firstly, Ruth, thanks ever so much. I'm Martin, one of the other non-exec directors. I suppose I was just picking up on your point around when you've had to speak to members of the crisis team, and you've had some that have been really good and really helpful, and then you mentioned one that perhaps wasn't so helpful. I mean, a really challenging area of business, isn't it, for our staff? I'm just intrigued as to how do we as an organisation almost oversee the quality of delivery of that service from individuals. I'm not necessarily saying that individual that wasn't able to help Ruth was somebody that's what they do all the time. It might just be that they weren't able to offer support at that time, but it just does make you think as to how do we oversee that service, and how do we ensure we're getting that feedback back on individuals that are doing particularly well and providing great support, and perhaps those that perhaps aren't providing as much support as we'd like them to.
Yeah. So I'm happy to pick up an initial response. I agree. I think what we obviously want to assure is that the first thing that Ruth talked about, where she felt as though she had a good response that was empathetic and people were able to listen, is the experience every time. So I think in terms of the quality, we mentioned last board meeting, we're improving the way we offer feedback from people who use services, their experiences. So at every episode of care, we offer people the opportunity to have feedback, and we keep an eye on that and make sure that where we're seeing patterns, if you like, of people having poor experiences, we've got an escalation response, and we can make sure that through our governance we address that. The second thing is, I think about the review about the crisis care centre is about looking at the pathways in that service. So how we have a lot of different clinical presentations that would come into crisis services. We need to make sure that we've got a response that's evidence-based, compassionate, and delivers a good outcome for people every time. So whether that's someone who may come into hospital because of an acute mental health issue, or whether it's someone having a crisis, which is a different sort of clinical reason, we've got responses that are consistent across all of those different clinical presentations. So for me, the review that we're undertaking needs to look at all of those issues and make sure that we've got things in place to ensure that we've got a really good experience every time, really.
Okay, thank you. Prem, and then over to Roger, but Prem first.
Hi Ruth, I'm Prem, another one of the non-exec directors. There's a couple of things there that you said just sort of resonated with me. One of them I might sort of ask you a question on. I think what Martin said and what Kenny's just said there, I think one of the things for me was about consistency of service. You don't seem to have got a consistency of service. It seemed to depend on who you were talking to as to what your level of service that you got back. So I don't know whether there's something there that we need to look at as a trust board and as a trust to sort of say, how do we manage that better so you get, doesn't matter who you speak to, you get the same interaction or the same level of service. The other thing you said in your little video there, you said that some of the staff were fighting against something. So I don't know whether that's something that we're doing as a trust in terms of processes, or not giving them the right level of support in order to engage with you. So I don't know if you could expand on that for me at all.
I'm trying to think what I said now. I think it just seemed like, I suppose from the inside out now I work in the trust, it felt very much like there were people, especially when I was under well-being, that really were trying to get me what I needed and really trying to advocate for me, but they were just hitting a wall, and it was like this invisible barrier, and they couldn't get me through it. And they really, they knew I needed the help, but I wasn't getting there. Or they go to, when after my additional session with the clinical psychologist, I think that they sent it sent it to MDT. And then after MDT, it was basically, obviously, it was people who didn't even know me, which is one of the problems. And they were like, oh, no, she doesn't need that, she needs that. And then nobody told me. And then there was a lot of miscommunication. And it took me months to find out what was going on. And I kept asking, but nobody would tell me what was going on. And I was like, I didn't need that. I was so stressed at the time. It was just really traumatizing. It was a battle of wills just to persevere. And keep, but I knew I need to keep, if I was going to get any help, I had to keep turning up for appointments. And it was only pure desperation that I kept going. So, yeah, it should have been a lot easier, really.
Yeah, thank you.
And there's a lot of also, sorry, just to add to that, I think it got cut out of the video, but I know there's a lot of communication issues. So, when I became really particularly bad, which was it worse after I joined the service in summer 2019. I was really bad when I went to my GP. My GP didn't know anything about my history of services. There wasn't even any notes to say I was even under secondary mental health services. He looked at me as if I just made up until I produced an appointment card. And he was just like, why have they done this? Why are you on medications? Like, what do you do with you? And I'm like, I don't know. And he was like, okay, you need to act for this, you need to demand this, this, and this. And that was the turning point, and it got me what I needed.
Yeah, okay, thanks for that, Ruth. I'm going to go over to Roger. Just put yourself on mute, Ruth, if you don't mind, just whilst you're listening, then you'll hear us better, I think. With you, Roger, again.
Yes, thanks. And Ruth, I'd be interested in your reflections on this, given your current training and work as well. I think addressing both what Prem said and also the previous point from Martin about how particular staff or in particular situations people may respond in ways that are not helpful, I think, and your responses, Kenny. I think part of it is also about maintaining a culture of supervision and supervision that is psychologically informed, so that we all have the opportunity to reflect on why we feel particular ways in particular situations with particular other people or patients. What is it that's being elicited in us as an emotional or behavioural response? And what is that? How does that relate to ourselves and our views? How does it relate to perhaps what is being projected from the person that we're seeing? This would be, to my mind, an essential part of supervision, particularly in the services that are working with mental health issues and so on. But and Ruth, clearly, with your ongoing training in psychology, I'm sure you'd have some thoughts on that.
Yeah, that's interesting, isn't it? It's a good point, Roger. Thank you. Yeah. Any other questions for Ruth or comments for Ruth?
Russell, just
Go ahead, Liz. Yeah.
Quick comment.
Kristen.
Hi, Ruth. I'm Liz Muller. I'm Chief Strategy Officer here at the Trust. Nice to meet you. I suppose in addition to some really poor communications and poor inexperience, I've sat here thinking about the world that I'm hanging around in at the moment and thinking about all the waste and all the inefficiency and you know how unhelpful that is to everyone, Ruth, the practitioners, everybody involved really, and how we need to be thinking about reducing that. Not only that will automatically improve a patient experience, but it will improve things for all the staff involved, and thinking about digital communication and how we do all that. It's just not right that we're still working like this in this day and age, is it?
Yeah, you're right. And lots of nods around the table, as you were saying that, Liz. Great. Okay. Ruth, I want to thank you for that presentation and also for answering our questions and commenting back. We wish you every success with the doctorate. It sounds like it's an exciting endeavour. We're delighted that you've made real progress, and I really like the thing that you said about, you know, staff here are changing lives. So, you know, that's enormously helpful to hear. But you've also laid a challenge back to us really about how we make engagement with service users more seamless, and we will take that away. What I propose we do is a little bit like last month. We make sure that this is picked up in quality committee, and if necessary it can come back here to full board, but I think quality committee is really the place to keep this under review. And is that okay? Good.
Yeah, I would agree. Can I just
yes, of course you can,
quickly say I think the key things for me, Ruth, and thanks for sharing your story, Kenny Lang, Chief Nursing Officer, are about that transition, that handoff, aren't they? So how can we make sure that continuity of care is ever present, and how can we make sure that communication is improved, whether that's with your GP, with yourself, ideally absolutely both. There's probably solutions around digital for that, and making sure people can access information really readily, and then absolutely the issue that we talked about around the right care every time, including supervision, including the work on the pathways in crisis services. So definitely we can record that and take that back through quality committee.
Great, thank you. I meant to say as well, Ruth, thank you for the peer support work you've been doing. We really value lived experience and peer support work, so thank you for that. Ruth, we're gonna finish this item there.
Okay.
You're welcome to stay, but you're also welcome to go. It's entirely up to you.
I've got a lecture to go to, so
yeah, great. Thank you. All right then.
Okay, thank you.
Thank you very much. Okay,
Thanks,
that's
Ruth.
great. We move on to the Reach Award, and I can see some familiar names on the screen, particularly Kim, who's related to this, I think. So this crew have managed to sneak out of actually being here in person to have the dreaded handshake and photograph. No, it's not dreaded really, is it? It's a lovely thing. But okay, it's over to you, Kenny.
Yeah, thank you, Russ. This month's Reach Award, welcome everyone on online. It's great to see you with us. Is for the general practice administrative team, and I've got some narrative here, so I'll do what Booker usually does and try and keep to the script and not veer off it. So it's fantastic to see you here, and congratulations for all the work you've been doing. It's fantastic. The award for Reach and the administrative team is in recognition that you play an absolutely vital role within the primary care directorate. You provide essential support across all the sites in primary care to ensure that the whole operation runs really smoothly, which of course is massively important, and that we're able to deliver high quality care to our patients who use general practice services. So there's a real commitment in the team, the nomination says, to support efficient cross-site working, which is really important, as we've got a number of practices who have got additional demands and varying demands put upon them, and we've significantly improved service delivery, which is fantastic to hear, and of course improved patient experience. The team are really dedicated, and team working is very present within the team. mutually supportive of each other, and it's been invaluable in terms of delivering high standards of care across all of our sites, which is fantastic. So there's a few specifics here within the nomination that we wanted to pick up in terms of the REACH award. First of all, improving the use of our resources, so our teams, so about rota management, trying to prevent service gaps and trying to maintain patient access across all of our general practice sites. Enhancing our performance in terms of QOF and QIF, which is really important to make sure that patients get what they require in terms of their care, and of course in terms of delivering what we said we would do in terms of contracts. You've done that by managing patient recalls, so making sure that patients are given the care that they need in a timely way. We've exceeded a number of targets in terms of the management of long-term conditions, which is part of that. Importantly, you've also supported the teams in terms of preparing for CQC inspection, which is never an easy thing to do, so well done on all the efforts on that. We ensure compliance across our governance processes and prepare people for that inspection experience, which has gone really well. We're really effective at identifying inefficiencies across our pathways, and the teams helped enhance patient communication. And also the team's been fantastic, really importantly, on relieving pressure on clinical teams. So, I know, being a clinician, if you don't have good admin support, that will put additional pressure on clinical services. So you do a fantastic job in making sure that all our clinicians can deliver as much time in patient care as possible. So that's really important. So lots of really positive work. I think it's fantastic to hear the work that you've done in terms of the nomination. And I guess what we would usually do at this point, because you've not here in person and you've been won't be have the opportunity to have a photo, is just to give us a round of applause from the board to reflect the really good work that you've been doing. Thank you very much. So we give a round of applause.
Great. So I'll just say thanks, Kenny, for that endorsement. That was really good. And I just want to add a personal thanks to Kim and the team. When I was a rookie non-exec director, the very first role I had 5 or 6 years ago was to chair the primary care subcommittee, and which is where Kim and I first met. And to have observed the progress since then, because that's the very early days of our venture into primary care, to see where we are now, to have brought more surgeries online, so that we're now, I think we've got 4, haven't we? The most recent one being Kiel. Just to see the transformation in service there, I think has been really remarkable. So I want you to know it is visible to us. We do see it, even though we don't always get to the front line that often. But thank you from me specifically. And I'm sure somewhere in the mix there'll be an opportunity to have a proper photograph with the proper chair of the board.
Wonderful. There just appears to be a colleague to the right. I'm not sure if they're intentionally trying not to get us.
Is somebody?
Great if they could just come a little bit.
Come on, take a bow. Very good. All right then. That's really good. Yeah. Now, the same as before, folks, you're very welcome to stay for the rest of the riveting board. But if you need to go and work, please feel free to leave us. But thank you very much.
Well done.
All right. Well done. Great. Okay, that was good, wasn't it? Thank you. And
brilliant.
with you, Kenny, now for CEO's report.
Yeah, thanks, Russell. So, again, the report is there for colleagues to read, so I won't go through every item in it, but there's probably a few things just to highlight. Firstly, we are firmly in the middle of the annual planning round, which explains the absence of Janet and Bucky today, who are in London at the national team, in terms of refining what the asks from the national team are, and Ben is at the staff system meeting, lock-in I think it's being referred to as, which is about trying to, yes, it's nothing to do with the pub, it's trying to finalise and refine our approach to next year's plan, which has been really quite a challenge. So it's very clear that the financial challenge for both the system and at a national level are highly challenging. As usual, we'll play our part in looking to resolve and support those issues within our system, and that we equally pay due care and attention to both our finances, our financial commitments, our operational delivery, and of course our keeping our eye on quality. So that is an ever-changing scenario, and of course we'll keep the board updated on progress with regard to that. The second thing I'd pick out was around Orbis and the start of our programme to implement our updated solution for electronic patient records, working with our partner Daedalus, which started off with discovery sessions. So we're engaging our clinical teams around the current state, and we're starting to envision what the future state needs to be in terms of how clinicians will use that electronic patient record. A really vital piece of work, and obviously key to delivery in terms of modernisation around our digitalisation, but also how we deliver care. So really important that we recognise that. And then lastly, to commend the work of our physical health psychology colleagues. Specifically, I would acknowledge Dr. Sabir Khan, who hosted an event at the Bridge Centre, inviting colleagues from across the Trust and other partner organisations and communities, and where the team discussed ways to improve equity and equality in terms of psychological therapy from global majority and minority communities across Stoke-on-Trent and North Staffordshire, which is a really positive event with great feedback and really underlines our commitment to try and ensure we've got equity of access and outcome for people of all backgrounds and protected characteristics. So 3 items there just to pick out of the report, but again I'm happy to pick up questions.
Thank you, Kenny. Good summary. Any comments or questions? We'll start in the room. Anything from anybody here on CEO's report? No? Anything online? Jenny or Karen? No? Okay, thank you. Well, we note the report. I was just thinking as you were talking about Orbis, it talks back to the point that Liz made really and was raised by Ruth, which is, you know, if we have a really good EPR, then some of this transition between teams and services that Ruth was explaining to us ought to be better. So hopefully there will be some progress through the rollout of Orbis. So that's good. The other thing that struck me as I was reading the notes in preparation for this is just the comment that the number one concern of the British public is access to a GP surgery. And of course we've just had a Reach Award. It's a shame we didn't keep them on really, isn't it? But there you go. Do we have a sense of how that is running in our own primary care settings? You know, do we have any sort of metrics that tell us about what people think about access to our primary care settings at all?
Yeah, so I'm happy to start, but Rachel might want to come in as well. So in terms of how we look at our performance around the primary care directorate, one of the key metrics that we look at is access times to things like telephone response times, appointments, etc., etc. So we do look at that very regularly. It's always a challenge, and we've done a number of things to try and improve that in recent years. So moving to digital, we've implemented digital access and booking systems. We've looked at improving our responsiveness in terms of our telephone response times, and again that's a key metric that we look at in terms of performance. So it's something we're very mindful of, and it's something we've done quite a lot of work on. I don't know if there's anything else you wanted to say, Rachel.
I think the implementation that we've utilised the patches system, which obviously has some challenges in itself, I think that does allow us to pull that data through so that we are able from the GP practices within the trust to look at have we got themes. And I think the award earlier is around where we've tried to utilise staff so that we're making sure there is equity across those GP practices as well with that access, and trying to make it as timely as possible, noting, you know, that is a huge issue for people in communities.
Okay, all right, thank you. Good. If there's no other points on CEO's report, I'll just say thank you, Kenny, and now we're on to the ICS, I think.
Yeah, so again, the report's there. It's on. It's in the papers for information. There is a briefing, so I won't go through every detail. The only one thing I did want to pick up was that there was a note in the briefing around the Darwin Centre, which the board has been briefed on previously. And Bucky did actually respond, but it's worth reiterating. We did have a period of enhanced oversight for the Darwin Centre. We've discussed that at Quality Committee. But actually now that enhanced period of oversight has been stepped down because of the assurance that was given to the Commissioner, which is the West Midlands Provider Collaborative, which works under delegated authority from NHS England. So just thought I would mention that. It is in the paper, but something that we've looked at internally. But apart from that, there's nothing else I was going to pick out.
Okay, thank you, Kenny. Any questions or comments on it's technically the ICB report, not the ICS, but any comments or questions? No, that's fine. We will come back to some of this when we get into private board later anyway. So just note that and we'll come back to it as we get to it. So thank you very much, Kenny. Next item is me stepping in for Janet on the Chair's report. Hopefully you've seen the report. Janet's helpfully kept it brief. I know that Janet would want me to emphasise the importance of LGBTQ plus month, were she here, and of course I completely, and we agree with that as a board. It's very important that we continue to be strong in our activity and our attitude to it, to do with inclusion, but specifically protected groups, and so this is part of that. And we'll keep on being proud and loud about our inclusive stance as a trust, particularly in the current climate. So I'd just like to thank everybody that got involved in LGBTQ plus month. It seemed like there were a number of really great events. I wasn't able to get to all of them, but thank you to staff for that. And let's continue to be strong in this area. The second part in Janet's note is about first of all, the MP's visit, so you'll note those. And then there was a visit, I wasn't involved directly, so others might know more about it, by Gillian Merron, who's under Parliamentary Secretary of State for a range of health-related issues. I actually went back and looked at these because, being a bit of a nerd like Joe in some of this stuff, we used to live in this world, I wanted to know what she was responsible for. So part of her responsibility is mental health. And as part of that, she's responsible for reform, children and young people, access, intervention, suicide and crisis prevention, and offender health. So to get Gillian here actually is a real coup. And if you think about the direction of travel that we are all observing at the moment in terms of the centralisation of power and decision making in the NHS, to get a Minister of State to come and see what we're doing is really important. So our thanks to all the people that are involved in facilitating that and making it a successful visit. Jenny, I've spotted your hand is up. Do you want to come in?
Yes, thanks. If you don't mind, I just wanted, particularly as the Chair's highlighted LGBT plus history month, just wanted to sort of just add a few comments to that.
Good.
Because you mentioned in there about some system work. We had I obviously worked for one of our partner trusts as well, NPFT, and chair their LGBT plus network, and we organised a number of events, and it was really heartening to see people from Combined joining into the system. Particularly Bucky, our chief executive, joined the last session we had in the month, which was about intersectionality, where we had a number of members of staff, rank and file staff, talking about their own lives and their own complexities with intersectionality within the LGBT community, and as the support from the trust is evident. We also, as part of that, presented outside, so I did a session with part of NHS England. I think it's a finance group within NHS England. I ended up being asked to, again, talking about experiences. Just a couple of sort of comments. We can't underestimate the challenge for part of this community at the moment, both in sort of the media and politically as well. And when I liaise and network with other trusts, I'm proud to talk about what we do in Combined to compare the situation in other trusts who seem to be rolling back on some of this work, seem to be hesitant in the face of the hostility that we're seeing in parts of society, particularly towards trans people at the moment. So I'm always proud to be able to go to that and say, actually, the two trusts I work for, particularly combined healthcare, have been hard and fast in support of everything we do. You know, we're ahead of other trusts in we've got policy, training. We are ahead of other trusts. I think that's really important to note. So I really am pleased that the chair's chosen to reflect this. It's very easy to think, if you don't live in the bubbles that communities live in, that things have improved and progressed.
Yeah.
I did a session on history over the last sort of 60 years, and you can see progress, and then you can see where it gets more difficult, such as the AIDS crisis in the 80s and Section 28. Then we see loads of progress, and then since 2015 we've seen real pushback and regression within the sphere, and people are more and more frightened and lives are more difficult. So I just wanted to add that context. I really appreciate the Trust highlighting it, the Chair highlighting this, and the support the Trust gives to us in this work.
Great, thanks Jenny. In my mind, I always imagine that when you're out there doing the various things that you do, I know you work for, you represent staff on behalf of ourselves and also MPFT, but I kind of imagine you're an advocate, you know, you're one of our staff going out really. I know it's a little bit more complex than that, so thank you for all the work that you do in this space.
Well, thank you for that. I mean, it's sort of become unofficially sort of my role now. But it's easy for me because I'm an oversharer, and you'll have heard me talk in this meeting before. But don't underestimate the courage it takes for people. I mean, I had 4 colleagues speaking at an event on intersectionality who'd never spoken publicly before, talking about their own lives, and never underestimate the courage that takes for people to share that wider. One of the colleagues is a very experienced public speaker, but then talking about his own life is really difficult. And I think we've done that, and Joel, I know Joan's sitting in the room there, that this trust made a point of letting people tell their stories across not just this community but every community, such as the patient story, and I think that has such impact. So it's easy for me because I'm so used to it, but there are people that are sharing things that are difficult for them. So thank you, Chair, for that.
Yeah, thanks. Great. Okay, with you, Roger.
Just very briefly, Jenny, coming back to I think something you were emphasising. I think we need to be particularly vigilant going forward. What we see happening in terms of the erosion of rights for people generally, the erosion of all the efforts that have been made to address diversity, equality and inclusion in other parts of the world are not going to go unnoticed, and they're not going to not have resonance. They already are having resonance in this country, and I think we need to be very vigilant for any ways in which insidiously the things that we value in terms of diversity and inclusion and equality and equanimity, all those things, might become eroded through things that may not be targeted directly at those, but financial stringencies and so on, where people start to redefine priorities in such a way that those kind of things start to drop off the priority list, if that makes sense. And we can see that happening in other parts of the world, and I think it would be good for us to keep a weather eye on that actively, perhaps, through our various committees, but also through this board meeting.
Good. I like the challenge, Roger. I think you're absolutely right. We can do that through committees. Quite a lot of the heavy lifting on that we see in PCDC, but the challenge really is to make sure it's riven through everything that we do and is not just something that we parcel off into a silo. So thank you for the challenge, and we accept it. With you, Martin.
So just following on that point, I suppose, some previous experience that I've had in relation to where things like that can get out of hand and conversations can start to develop are things like WhatsApp groups, unfortunately. So I kind of think that's one as an organisation we might just want to think through as we move forwards, and in any messaging that we are putting out internally, we might want to think about reminding individuals around the use of those types of social media groups for conversations. Again, it's just a thought that tends to be, from an organisational perspective, where you can find these types of conversations that are not the kinds of conversations that we would want to happen and support can start to take place on those types of groups.
Absolutely. Sorry, quick comment in support of that, Chair. I saw an article the other day about the extent to which the term retard and retardation is being used by the Trump administration and their various ones as a very public word of criticism and denigration of others. And you will understand from the point of view of people with intellectual disability, and previously being called retarded and continues to be called retarded, quite what that means.
Yeah,
but it's something else that slips into media chat.
Yeah, great. I've seen Kerry and then I've seen Joe, so we'll go in that order.
Yeah, and thank you for Jenny's kind comments in terms of the trust being ahead of the game with some of these pieces, but I think vigilance is absolutely required, and I think we can't be complacent. We still know that there are many experiences, both service users to staff and staff to staff, that we need to keep vigilant, and that bias remains within. So we have done lots of work, Jenny, and I suppose it's that commitment that EDI and inclusion belonging remains one of our committed programmes as part of our people plan and people strategy. But we are seeing some erosion landing, both from service user perspective and from a staff perspective. So that bias and that unconscious and conscious bias, we need to keep working on, and the board needs to be cited on that and really set the tone around what our expectations are around that piece. So it's been a while, I think, Jenny, since we've done anything particularly around trans and our commitments around this, so it might be something that we want to pick up as a board from a development session along the line to ensure that we are all.
Yeah, good suggestion, thank you. With you, Joe?
Yes, so just a couple of things. So Jenny obviously mentioned patient stories. We've also got our podcast. We were one of the first trusts to create a podcast many years ago, and I would recommend. We did a fantastic podcast with Jenny about her experiences of life as a trans woman, which is well worth a listen for those members of the board who aren't familiar with the podcast. We can get that on SoundCloud. I was just going to just reassure you that on social media we do have a social media policy, a strong social media policy. We reviewed it, I think, last year, and it's been explicitly designed so it can flex across general principles across emerging technologies and all of that, and particularly it does include WhatsApp and with some guidance there about acceptable behaviours. So we do have that.
Yeah, thanks, Joe. And over to Jenny Koo.
Yeah, thanks. I was just going to comment on a couple of things that both Roger and Martin raised there. Obviously, what is going on over with the US and the Trump administration, some of the wordings I guess we just need to be mindful of, particularly when I was referring back to the ICB update, where there's a comment in there that says, there's a highlight for the need for tough choices to work within the resource provided. That specifically resonates quite a lot with the narrative in the US, for instance. It is highlighting specifically, when they talk about that in the US, it's, DEI programs are not worth the resource, basically, is what they're saying. So it's great to hear, Kerry talking about, we continue to focus, and it is part of our people plan. But I think what we do need to do is also be very mindful that the staff and I guess some of the feeling behind it may start to impact individuals kind of towards it if they are feeling that kind of resistance globally. So I think that's something that we definitely want to keep an eye on going forward. And then the other piece I was just tagging on to Martin's point about social media. I mean, even things like, I love seeing the posts on LinkedIn that we do and all the great things there. Like, how do we respond to comments like LinkedIn has got to the point now where actually people aren't particularly PC on there anymore. I think if we're silent, if anything is in response to our activities, if we're silent, we need to have a think about how we respond to those, especially if they're posted on our kind of pages. Our pages. Yeah. Because that can also give a feel for our staff, in terms of what do we do. But I'm sure Joe's got comments.
Yeah. So sorry, I'm just multitask here. Right. So our general approach to social media is we don't tend to get involved in direct discussions or debates, publicly on social media. But what we do is anything that that we see that we have some concerns about is escalated internally, and in the social media policy itself, both to our own staff, but also to more generally, we do explicitly say in there if there is something that is dangerous or that we consider to be either a sort of threat or attack on us, we do reserve the right. I think the phrase we use is to escalate to the appropriate authorities. So we do keep an eye on it. We don't actively get involved in public debates on the channel.
Yeah, no, that's completely understandable. I think in terms of what I was thinking about is how do we communicate that kind of response internally to show that support for our for our employees and our users, etc. Service users.
We do that through established channels.
Excellent.
Okay, thank you, folks. Well, let's continue to be vigilant individually and collectively, corporately as an organisation. But I think that's been a really helpful debate. So thanks to everybody that's contributed to it. And no doubt we'll come back to it regularly because it's important. Just want to check, are there any questions from the public? It's a relief, isn't it? Great, okay. Let's go to a break. So